Right, right.
For this entire series, just to clarify, Dr. Omkar is the boss.
Okay, madam. Thank you.
Follow what he tells us.
Okay, good. Thank you.
So I request RX event, let's go on live. And once we are on live, please confirm me that we are on live.
Yes, sir, we are on live.
With the permission of our faculty and our course director, I'm starting this program. Good evening to everyone. I'm Dr. Omkar Swami on behalf of MQ Pharmaceuticals Limited. Welcome you all in this very interesting program of Acute MI workshop. So we have conceptualized this program, and we thought that it's around a right time to discuss more about the thrombolytic therapy in current pandemic area, and then understand how the myocardial infarction can be managed effectively during this time. And this program we have reached to Dr.A.Sreenivas Kumar sir, and he has actually conceptualized this program. So whatever the program you are seeing today, there's a lot of soul and heart has been put forth by Dr.A.Sreenivas Kumar sir. So it gives me a pride, privilege, and honor to welcome our course director, sir, Dr.A.Sreenivas Kumar sir. We know sir is senior consultant cardiologist and director of cardiology and clinical research at Apollo Hospital, Hyderabad. Sir has been a chairman of a FACS Professional Services, and he's a founder editor of national medical journal called as Postgraduate Medical Clinics of Usmania. He's a founding course director of Advances in Cardiovascular Solutions, TCT India and South Asia Conference. His area of interest is TAVI, ASD, IVERS, and etc. He has been also president of Cardiology Society of India for Andhra Pradesh chapter. Being a director of clinical research at Apollo Hospital, Hyderabad, he has been a part of many important clinical trials. Thank you very much, sir, for indeed your guidance. You have always been a friend, philosopher, and guide to us, and your keen interest is making this program successful. Thank you so much. I also welcome our moderator, Dr. G.L. Sharma, sir. He's a director at Jaipur Heart Institute at Jaipur, and he's working in this institute for last maybe more than 15 years time. And he's an experienced interventional cardiologist based at Jaipur and also visiting fellow at Tel Aviv University, Israel. And he has been an ex-consultant cardiologist at PD Hinduja Hospital, Mumbai. I also welcome today's presenter, Dr. Salil Shirodkar from Mumbai. He is working as an interventional cardiologist at Nanavati Super Speciality Hospital in Mumbai, and he will be presenting on acute myocardial infarction to primary angioplasty. I also welcome Dr. Navajit Talukdar sir from Delhi. He's a senior consultant and interventional cardiologist and electrophysiologist and pacing expert at Batra Hospital, Delhi. He will be presenting on cardiogenic shock with corona. I also welcome Dr. Preetam Krishnamurthy sir from Chennai. He is consultant interventional cardiologist and assistant professor of Department of Cardiology at Sri Ramchandra Institute of Higher Education and Research, Chennai. He will be presenting on the need of pharmacoinvasive approach. So at this point of time, I take a pleasure to welcome our executive director, Mrs. Namita Thapar. She is also very keen in this program, and we have initiated similar kind of a program in interventional cardiology called as no thrombosis. So similar kind of a program we are working out here in a thrombolysis. And over to you, ma'am, for opening remarks.
Good evening, everybody. It's a matter of absolute pride and delight to be part of such a wonderful scientific initiative this evening. And Dr. Swami mentioned about no thrombosis, and I was just with Dr. Sreenivas Kumar on that as well a week back. And doctor, we started at 8 o'clock, and it was such a vibrant discussion that instead of 9:30, I think almost we ended at 11:15. And I must say that the commitment with which Dr. Sreenivas was there, giving his feedback along with Dr. Hiremat and Dr. Jabir, was absolutely inspiring. So I must start by thanking and expressing my deepest gratitude to our course director, Dr. Sreenivas Kumar, and to our moderator, Dr. Sharma, because you are taking out the time to really guide and mentor some of the brightest people here who are going to be presenting their cases. Dr. Shirodkar, Dr. Talukdar, Dr. Krishnamurthy, I thank you for making the effort of presenting your cases and being a part of this discussion this evening. And with that, I wish you the very best. And again, thank you, all of you, for sparing your time for this wonderful scientific initiative. All the very best.
So thank you very much, ma'am. I take the privilege to welcome Dr. G.L. Sharma, sir. He has just recently joined. Welcome, sir. We have just started this program.
Thank you.
So at this point of time,
good evening, Sharma ji.
At this
Hello, Sreenivas. How are you?
Yeah, fine. Good evening.
Good evening. Good evening.
Yeah.
So at this point of time, let's reach out to our course director, Dr.A.Sreenivas Kumar, sir, for giving the background of this program and how we are going to progress on this program. Over to you, sir.
Yeah, thank you, Onkar. Thank you, Namita madam, for your words of appreciation and encouragement. And a lot of hard work is done by Onkar, Nana, and many others for making this program possible. The idea was how to make usage of this molecule very comfortable to the physicians so that the patients who require this drug could benefit. This drug comes with a, what you call in obstetrics as bad obstetric history, with something, some complications created by streptokinase before. Though we should appreciate that lytic therapy started with streptokinase and it produced a lot of good in ICS trials and things like that. But because of the nature of its preparation and the side effect profile which it had, all of us, ever since we were students onwards, we had some issues with the usage of the molecule, because once the molecule starts, there is hypotension. There's some patients develop allergic reactions. We are using antihistaminics, we're using steroids before giving that and all that. But still it worked in 50-60% cases. I was not disregarding the introduction of that molecule, because that's how the thrombolytic therapy switched away from just absolute rest. When we were just born, Madam Namita and Onkar, you must be interested to hear what is the acute MI therapy. You know, just absolute bed rest for the patient, nothing else. For weeks together, patient has to lie down on bed. That's how they were developing deep venous thrombosis and other complications. We had no other drug. Then the aspirin came. Then, of course, streptokinase came. We should be always happy and we should give that respect to the drug. Then in between, primary PCI came, but the primary PCI problems were non-availability in multiple places, especially in a country like India. So that's how I got interested in this new molecule which came. I think you made India proud by making tenecteplase. We should be congratulating MCure for this. And this also, other beauty of this molecule, I'll just briefly mention in 2-3 minutes how it evolved also. A lot of people think that this is not backed up by data, or this works in some patients, doesn't work in some patients. But what I would see, the tremendous advantage of this molecule is its safety and the convenience of usage of this molecule. And the way it works, in absolutely in 80% of the patients, it works like a thrombectomy. In cath lab, as we know, primary PCI, we suck the catheter out, clot out. Similarly, this molecule dissolves the clot and suddenly patients improve. Hemodynamics improve, heart rate, blood pressure improves. Like we have seen many such examples. And the third is the fibrin specificity of this molecule decreases the complication rates which used to happen, hematomas which used to develop. And when we were taking these patients to lab later for whatever we used to call before as a facilitated PCI, now we call it as pharmacoinvasive, is a lot of complications used to happen because of plaque rupture, femoral hematomas, and all that. Now we changed to radial, that one happened, and as well as the fibrin specificity doesn't lead to much of complications, even if some unfortunate 10-15% of patients who have to be taken to lab for primary PCI, again, complications are much less. So that's what is the most important message with this molecule. And this data evolved through Ascent trial, group of trials 1, 2, 3, 4. I will briefly touch upon the discussion later, rather than take too much time in the introduction. But other important thing, what I wanted to mention about usage of this molecule is, whoever is comfortable in giving IV injection, they can give this molecule. That's the beauty of this molecule and convenience of usage. But the problem even today, I would say, is which patient has to be given this molecule is important. that confidence and comfort level of diagnosis of acute MI and the right patient and excluding the contraindications, there's no bleeding, other issues, is important even in today. And sometimes that is a challenge. So what we advise that's how I got into a lot of IMA colleagues and API physician colleagues across. And whomever you are comfortable with, you tie up with one of the cardiologists close by and whom you like, and use the technology. Previously, when we started this pharmacoinnovative approach, we had a GE requesting them to give machines, ECG machines, which will have again reporting through all the servers and all that is not required thanks to the technology evolution. WhatsApp is doing all that, and need just taking it to the cardiologist nearby and confirming the diagnosis. That's what is very important. Once the diagnosis is confirmed, if it's given to the right patient, definitely we are very sure that this produces a lot of benefits to the patient. Other important dilemma which many physicians worries, which physicians have, I would like to again clarify, that is they're worried to keep the patients of acute MI longer in their clinics. Like sometimes they develop hypertension, sometimes the situations are also not good. You see, patients suddenly worsens, they're all worried. So this molecule gives that advantage also to them. This is drip and ship types. Basically, give the molecule. If you're not comfortable, you can immediately transfer this patient. That's what we have proven. Even if the patients are transferred immediately, there are not much of problems happening during the transfer. So that is another beauty. If you have a molecule, it does its purpose, and the patient can be transferred to higher centers without the doctor who is involved in getting into trouble also. Though I would assure that once the artery is open, then the patients would have less of side effects and complications happening. The problem comes in, unfortunate, about 15-20% of patients where this drug may not work. And that is the issue where if it's shifted to for lysis also, pharmacokinetic strategy, you send to primary PCI, there's not much of problems happening, provided you avoid that first 2 hours where there could be more little bleeding tendency. By the time patient lands up to higher centers, that critical period is over. And so even if you take the patient for PCI 3 hours, 4 hours, you would have no complications and have good results. And another important thing which I would like to highlight is when you're transferring the patient, the only important thing we should not forget is obviously antiplatelet drugs we give them before. And then when you are giving this molecule and shifting this patient, please don't forget to give a touch of low molecular heparin immediately. Otherwise, the worry of reocclusion rates, what we have, will be little more. I think with these are the important things which I wanted to mention. All the presenters also to feel free to discuss any of the points in between, because it should be more like a interactive discussion rather than just didactic lectures. Dr. Sharma, sir.
Good evening, everybody, and it's my pleasure to have this wonderful meeting by Amcure, and what Dr. Sreenivas is mentioning about this wonderful molecule. And nowadays, since last 1 year, the COVID era is going on, pandemic is going on. So once the periphery central streptokinase is a problem because there is a hypotension, arrhythmias, and transportation problem. This molecule can be used, and it is a safer, just like injection, and you can transfer patient from there. And for the primary angioplasty, and even for the facilitated angioplasty. So I think this molecule is better instead of streptokinase, urokinase. One thing I was listening to Dr. Sreenivas is mentioning about the low molecular weight heparin. I don't have much experience using low molecular weight heparin before primary angioplasty or facilitated primary angioplasty. Once we have used the low molecular weight heparin, the dosage of regular heparin should be adjusted. So I think for physician level, I think we should teach them use this thrombolytic, either streptokinase, urokinase, or this Alexium, and even you can refer directly without any monitor, and then tertiary care center will take care. So this message should be for the periphery physician. And don't worry, if you don't have the monitor, you don't have any problem. There is no allergic reaction to this drug. This is a safe drug and you can use. So I think in that way we can save the patients and we can prevent the lot of arrhythmias and hypotension by using this drug. Thank you very much for giving me this opportunity.
Sharma sir, why I was mentioning about low molecular heparin was when we were in streptokinase era, it was contraindicated to give heparin for first 6 hours, because if they given heparin, there's more bleeding happening in these patients. So all the physicians have that mindset that heparin should not be given after the lysis. That's why I was highlighting, because the shorter half-life of this molecule, it is mandatory to give either that or a low molecular weight heparin, because studies compared heparin at low molecular weight have showed slightly advantage of low molecular weight heparin. It's also convenience for its usage. So many physicians think that first 6 hours of acute after lysis, where you have more of a tendency for bleeding, you should not give heparin. That is not true with this molecule because of its short half-life. That's why I was just highlighting that. You also mentioned the same. I think with these comments, we'll go to presentation.
Yes, sir. Yes, sir. And I'm very pleased to tell you, sir, 1200 participants are already online and they are watching these programs.
Oh, great. Thank you.
So we can move to the first case, sir.
We should be also thanking my local IMA president, Dr. Sairam, good friend of me, and also our API secretary, vice president, Dr. Narsingh Reddy. All of them who helped it, and they all were interested for this, in fact, to learn about this, because it's useful and life-saving for all. So thank you all, and over to cases, then we can have a discussion.
So we'll go to the first case by Dr. Shirodkar, sir. Over to you, sir. You can share your slides and we can go ahead. You're on mute, sir, Doctor. Please to unmute, sir. RX Events, can you just help? Dr. Salil Shirodkar, can you just unmute?
Hello, Salil sir.
Yes.
Salil sir, can you hear me?
Yes, we can hear. Dr. Salil, we can hear you, sir.
Yes, so good evening, everybody. Thank you so much, and thanks to MCure for inviting me for this case presentation. I would like to add few points about my experience about this wonderful molecule. As Dr. Sreenivas has already mentioned everything, the good points about this molecule. Previously, with the previous generation thrombolytics, we used to see post PCI a lot of slow flow and no flow in these vessels. But with Elaxim, these slow flows and low flows are very less. There are very few other indications that we have tried in the cath lab using this molecule. One I would like to share is like when we had done a peripheral angioplasties with lot of thrombus, arterial thrombus. We have actually given a bolus with a fountainhead catheter in the peripheral vessels. And we had an amazing thrombus clearance after giving a peripheral thrombolysis in these patients. Other thing is that in the cases of massive DVTs, we have given a catheter-guided thrombolysis in the pulmonary veins. And there also we have found a wonderful results with this molecule. In fact, we had done recently one case where a patient has got a hip replacement, bilateral hip replacement, and developed a massive DVT and then pulmonary embolism, where we are given a low dose catheter based thrombolysis, and we could got away, in fact, without any post-operative bleeding complication. So these are the few very important points about this molecule that we have found here in Bombay. And I would like to go ahead with my case. This is acute MI. The elderly guy who had hypertensive diabetic had a rest angina for a few hours. What we found in our A&E was he had already had an evolved anti-revol MI. Being enzymes being positive, mild LV dysfunction, we took him to the cath lab. And cath lab where the LAD was totally occluded after the first diagonal. And if you see the course of that LAD was very difficult to negotiate. So this was a total LAD occlusion. And the cranial view, especially the course of that LED was very unusual. It was a second diagonal which had some disease, and after that, if you see that the tortuosity and the course, which is almost a 90-degree turn in that LED. So right coronary and circumflex were clean, so we decided to go ahead with angioplasty. I wired that LED with the Fielder FC wire. So the wiring was very difficult because of the anatomy of that vessel. It had a 90-degree bend right at the origin of the diagonal. But eventually with the Fielder, we could manage to wire that. Patient started developing chest discomfort and hypotension. So I had to go ahead and dilate that LED immediately. There was little difficulty in negotiating those balloons. It is little calcium and the anatomy, which was being very tortuous. But we managed to dilate with the balloon. This is a 2.5 12 NC sprinter. So post dilatation, we had achieved a flow in the LED. And to my surprise, after having a flow with the clear anatomy, there was a difficulty in rewiring that diagonal because I wanted to save that diagonal, at least wire that. So initially I tried with Theon blue wire, but the course was, anatomy was a little difficult. So I thought that it is going subintimally. So I kept that wire there, took a BMW, wired that diagonal. And we decided to stent that. Stent negotiation was also very difficult through the course because of the calcium and the anatomy of the vessel. But we could pass those stents. I deployed 3.0 onyx distally and 3.5 onyx proximally, covering that diagonal. So this is a distal stent. And then it's a proximal stent. So fortunately, there was a TME3 flow post stenting in a diagonal. So we rewired everything. I recross through the struts in the diagonal. And then post dilated the proximal part with 3.5 balloon. Patient's hemodynamics got better, ECG got settled down, but he was still hypotensive post-MI, so I never went ahead with the imaging at that same go. So this was the end result. Just wanted to elaborate. The anatomy was very difficult and the tortuosity and the calcium. Finally, we could manage to achieve a TME3 flow in that. You can see the stent boost images. Stent boost images looks, stent is well expanded. So I deferred the imaging at that particular go in view of little unstable hemodynamics. Thank you.
Thank you, Dr. Shirodkar, for showing this interesting case. I missed that initial thing. It was given lysis elsewhere and shifted here, or patient directly came for primary PCI?
It was given a lysis and then been shifted. That is why I said that the patient had some flow in the LED.
Yeah, that's what I precisely wanted to mention. This is the advantage even for interventional cardiologists, as what you said.
Right.
The sort of difficult anatomy, if you don't have any tract, it becomes very blindfolded for us.
So it would have not been lies. This patient would have not been lies. I would have not been able to figure out from where exactly that LED is coming.
Yeah. I think
Second
I
thing I
request.
just wanted to say about this molecule that I have, seen post lysis, very less patient going for a rescue plastic. This molecule is so wonderful. It's giving us a time, that to go ahead with the pharmaco-invasive therapy. With the previous molecules, we used to have a lot of rescues, patient getting unstable, arrhythmias and everything. So rescues are little less, and rescues become very tough to manage in the cath lab sometimes.
Yeah, I think that's a good point what you mentioned. And the artery, by the time it comes, at least the faint trickle makes our life lot easy in the cath lab to wire it. And now you went to the extent of actually wiring the bifurcation
figure
also.
Out from where exactly the track is.
Yeah, yes. And you also could dilate go into the wire, and the side branch also you could do it and save that branch too. And another beauty is we should be also thankful to the new stents technology which is available, which are improved. So you, in spite of the elderly, tortuous, calcific vessels, still we could track and get the good results. I think one other point which I wanted to highlight is once you wired it, suddenly patients could become unstable. We need to be geared up because of that, because the wire, suddenly whatever that flow which came, trickle of flow which comes after lysis could have decreased because the wire could approve that flow, and patient could develop hemodynamic disturbances. That's why we should be geared up immediately to take a balloon and dilate it so that the precious time is not wasted. And this is again, finally, it's very important. Oh, sorry, I was not able to, I was not audible all this time. Sorry. So what is said is basically we should be thanking the new technology of stents also which come, and then probably we could track and position it. And
probably this is the ideal case of combination of everything, using that Elaxim and good quality stent and in the cath lab and little luck.
And right start to our this program. Somebody is muting me. Onkar, you can tell them not to mute.
Yeah.
Okay. So what is happening? Suddenly, if it's muted, then I'm missing out some things which I'm mentioning. So a good example for our start series of this, where pharmaco-invasive strategy, how it works and how it helps, is clearly, effectively shown. And what I was mentioning can you run the left picture? Just click on the left picture, which was pre-angio. Yeah, see that the very faint track which comes, that also helps us a lot in taking the wire in properly. Otherwise, without that, in this tortuosity, wire tends to go into branches. We waits a lot of time. So sometimes
probably total at that origin, we could have not been figured out from where exactly the LED is coming. It is like actually taking a 90-degree bend, and then from distally it is coming. So we would have not been able to figure it out without a lysis in this case.
Yeah. Suppose even if it is not done the total job, it generally does the total job where you may not need stent also in young patients. But in elderly patients, this is the advantage of following the pharmaco-invasive strategy. And that's how it helps. I think obviously you put these patients along with it on good antiplatelet drugs. And the patient slightly delayed, I think, presentation. That's how there is some element of still hypokinetic movement at the apex. But that's what we can do. That's how the patient education is most important. The coming on time is most important in spite of all the technology or everything. Though this pharmacokinetic strategy helps us to decrease the time of revascularization significantly, but if patient, even in the peripheral center, comes very late, it's always a challenge. So the earlier the patient comes, especially if they come within first 2 hours, I think even the lysis results are as good as primary PCI. That's what it said. As the patient gets delayed, then that's where the primary PCI keeps on having some advantages. I think you have excellent presentation. I think we had good thing. Sharma sir, any comments on this case?
I think this is a very good example of pharmaco-invasive strategy, and Dr. Shirodkar performed a complex PCI in a very simple manner. He did the bifurcation. But only thing, have you used the nitroglycerin after angio, because your artery looks very small before when you are in the first shot? And
I always use nitro and nicoron both.
Okay. In spite of that, nitro and nicoron artery was looking very small, and when you finish the procedure, and artery looks very well. It's a difficult procedure, and you got away without having any slow flow and no flow. I think this must have received this Elaxium previously. So
Elaxium will happen in both.
And you must have loaded this patient with the Brenta, something like that.
Yes.
I think congratulations for having a difficult case in a very
Thank you so
simple
much.
manner.
I
Thank you
think
so much.
if you do with good intention, I always keep telling God also cooperates and helps in making better outcomes to the patient. Slow flow sometimes is not in our hand. Whatever you do, sometimes suddenly patients do develop. Though the most important thing for avoiding slow flow is a patient coming on time. One, if a patient comes late, whatever you do, still there could be slow flow. Second is because this patient had lysis with this molecule, less chance of slow flow. And other thing, slow flow is the more longer the nature of disease and more longer the stent, there could be more chance of slow flow. But in spite of 2 long stents, patient had good result, and that's how I think patient.
That's why I was mentioning, because he used a long stent.
Yeah, true.
Artery.
Lesion was like that. That's why he was forced to use
So
2 long
one
stents.
more thing is that the hexabric dye also helps sometimes, with the contrast also sometimes can precipitate this thrombus, especially in the thrombotic lesions. So that hexabric dye also helps.
Especially in ionic contrast era, we were having a lot of trouble, but in non-ionic contrast era, it is less of a problem, but sometimes it could matter, especially when the patient has a compromised renal function, things like that. We should be more careful with the contrast also. I think we had a good discussion. My good friend Dr. Sai, did he join now in the faculty? Can he have a few inaugural comments with this? Is he there?
Doctor?
Sai?
Yes,
Is
sir.
he there? But Sairam?
I don't think so.
Okay. Anyway, he's joined in that other link, I think. What I wanted to hear from him is what are the things which practitioners want to understand about this molecule, because we should always try to remove apprehensions what they have, and then that's how the usage of this molecule and the real benefit of these patients to keep happening. I think that's why I requested him. They're shifting him into faculty thing because their platforms are different. Others cannot join it. I think they will do it. We'll go for the next case. By then he will join in this.
So, Sir Dr. Nabajit Talukdar would be presenting the second case of cardiogenic shock with corona. Over to you, sir.
Yeah, very good evening. Am I ready to share my screen?
Yes, sir.
As Dr. Nabajit becomes ready to present, what I would like to mention is, though such case examples of cardiogenic shock happen, but thankfully it is extremely rare. It happens in about less than 1% of cases of COVID. So all the patients, once they get COVID, they will be worried, terrified that they would land into this. But fortunately, this sort of thing happens in a few percentage of patients, and complication rates are like going into shock type of situations I'm talking is much less common. But once they go into the phenomena of SARS-like syndrome shock, then it's a vicious circle. That's how they don't do well once they become bad. But by and large, 95% of the patients would be okay, and provided they come on time to the hospital and we give guideline-directed therapy. These are the words of reassurance I wanted to give to all the doctors who have logged in. Over to you, doctor, for your presentation.
Sir, thank you for a kind word. In presence of such galaxy of persons, like I feel humbled to be allowed to present this case. Well, these are the corona times, and in Delhi, we faced horrible times last 2-3 months. Of course, now there is a little bit respite. Well, are my slides visible?
You click on your slides, sir. You click on that becomes big.
Okay.
The PPT.
So, are my slides visible?
That's
No,
what
I think, sir, you need to unshare and then again share. You can unshare the things and then you can open the PPT and then share, sir.
Okay, I have unshared and again sharing.
Yes, they are loaded.
Now
they are loading. Yes, now we can see. You need to just make full mode.
Perfect.
Okay. Sorry for the glitch. So, well, this was a 65 years old male, hypertensive, and he was the Khadim, one of the 5 Khadims of Hazrat Nizamuddin in Delhi. That's a very famous religious place. He had the history of post-CABG, 3 graphs, 2009. Details was not available. He was unlucky enough to suffer from fever and cough for last 7 days. And on 4th day of fever, he started having crescendo angina. that means before presentation 3 days, he was having crescendo angina. Since one day, he was having acute breathlessness along with some altered sensorium. ECG showed diffuse changes, but more so 1 to 1.5 millimeter ST elevations in the inferior leads. Corona test was done, CBNAT, it was positive, 13 by 25. Echo showed 45% ejection fraction. The basal segments were hypokinetic. There was some mild hypokinesia in the LAD area and their lateral wall. The cardiac enzymes were sky high, 12,000. The patient was in pulmonary edema. He was having depressed urinary output, altered sensoria, BP less than 100, making some form of a cardiogenic shock or an impending shock. We decided to immediately take the patient into the cath lab. Before taking the patient into the cath lab, there was a lot of discussions regarding whether it is pulmonary edema or other things. We decided not to go for the CT, in fact, look at the echo properly. When we relooked at the echo, we found that along with the basal segment and inferior wall hypokinesia, there was some acute MR. So we were sure that some coronary events were happening, and then we took the patient for the lab. This is the native vessels, LED 100% occluded, circumflex quite significantly diseased, and the RCA native was diseased. The RCA was having a large RV branch, which was showing disease, but that could not have accounted for cardiogenic shock. So this was another view of the RCA, native RCA. When we looked at the grafts, we found that there was a rat tailing of the RCA graft, suggesting an acute occlusion. The circumflex graft was also occluded, showing us a stump. I'm sorry, it is not running. There was a stump in the circumflex graft. I'll come to it later on. Okay, it has started to run. You can see the circumflex graft is having a stump, and a large thrombus is already seen hanging in the circumflex graft. So there are two grafts. LAD lima was patent. The head, body, toe was quite okay, but distal LAD was, badly diseased vessel. So we thought that we'll go behind the grafts. Since there were some ECG changes, we thought that we will do the RCA first and took up multipurpose catheter, hooked the RCA graft. Lesion was crossed by a whisper ES wire, and on simple wire passage we could found some dye tickling along. Then we went for the ballooning of the segment with 2.5 into 12 mm balloon, and post ballooning we did daughtering with the same balloon with an idea of propagating the thrombus, because RCA graft is many times having large.
I think, sir, you're on mute, sir.
Yeah, somebody had muted me. Anyway.
Please, RX events, please don't mute the people, please.
Okay, am I audible now?
Yes, yes.
So after just daughtering, we could find some, you can see some fragments of thrombus already hanging, and there is also a fragment lying over here, but there was a good flow. Then we decided to take a stent. So in this case, the stent was Yukon Choice Elite, 3.75, 3 into 36 stent, and we implanted the stent. As we were implanting the stent, there was some arrhythmia, VT. We cardioverted, and in the process, the stent migrated a little bit further. So there was a geographical miss, or maybe a stent, or maybe a plaque shift, resulting in the proximal segment, there was some residual lesion. So that part had also to be covered. with another short Yukon Choice Elite 318 stent deployed at 12 atmosphere pressure with a 2 millimeter overlap. And then this was followed by post-dilating of the segment. This is the deployment of the stent. Post-dilatation, serial post-dilatation from distal to proximal. So after diligent post-dilatation by 3.5 into 12 mm NC balloon, we could find good results. I'm just coming to that. So in the end, we could get a good, decent result in the RCA. And at this point of time, the BP slightly started rising. We could see in our monitor that BP was somewhere hovering around 90 with the pressure tracing becoming better. As the patient was becoming better, pulmonary edema continued. But then we thought that something should be done to the graft to the OM, because that is perhaps responsible for transient pulmonary edema producing MR. The OM graft was having a large thrombus burden, in fact, a very nice PP looking thrombus hanging around. So this was again the multi-purpose catheter, which was used to hook. We passed on a wire across the thrombus, and we decided that because the thrombus was like, initially we took a thrombuster, but with no help, we decided to pulverize the thrombus. Then we took a balloon, a short balloon, 2.5 into 8 mm balloon, and tried to place it across the thrombus and with an idea of breaking the thrombus and pulverize it. This we did along with multiple passes of thrombuster. We tried to break the thrombus and gave 5 or 6 passes of thrombuster. So even after the thrombuster passage, we were not into much luck. Only the P size area has decreased and thrombus is somewhat broken. We decided we will further do it along with intermittent breaking of the thrombus and then going for thrombuster. In total, we had around 12 passes of thrombuster. So after diligent dilatation, we decided that since the vessel was full of thrombus, then with the same balloon, we'll go forward and with low pressure, we'll try to make space all through the vessel. That's what we did. Along with this, at this point, we also gave GP2B3A inhibitors. After GP2B3A inhibitors, since some tickling of flow was happening, I'm sorry, somehow it is getting delayed. Some tickling of flow started happening. Intermittent, it would close down. We stented this area with a 2.75 into 21 mm Yukon Choice Elite stent. And with the same stent balloon, we decided to make way within the thick part of the thrombus. We also gave intracoronary STK with an idea to make some way ahead of the thrombus. With the use of intracoronary STK 1.5 million units, we could see some flow happening along the vessels. Then all the pharmacosteroid things done, intracoronary adenosine was given, intracoronary nicorandil, intracoronary adrenaline, with everything and all the tricks of our slave, whatever we could matter, we seem to achieve some flow. And on the intraprocedural echo, we found that the MR has decreased. The BP rose to around 100, and it is at this point what we left the disease. Although not a very good flow, but some flow happening. You can see the lateral wall already starting contracting quite well after the graft was opened, resulting in decrement in MR and in improvement in hemodynamics. Luckily, the patient did not need intubation. So we can say that venous graft intervention during corona may be challenging at times in shock situations along with corona. All the coagulation pathways in hair, this becomes more challenging. Ideal antiplatelets and anticoagulants are still evolving. Often diligence is what it pays, although I don't claim it to be so. I just did go on, went on doing in the interest of the patient, and with all whatever experience little experience we have, we try to think. And I must emphasize that there is no one or none laws. We have to individualize laws and our tricks of the slave according to the situations what it demands. This patient was done 2 months back. Around 7 days back, he had come to me walking, and his ejection fraction is improved. Right now, it is 50%. There is no MR. He is not having an angina, and I was lucky by the grace of Almighty to have saved him. Thank you. And I wish to learn from our learned audience what differently they could have done and what other paradigms may be there in this case. Thank you.
Sir, I take a great pleasure to welcome Professor Nakul Sinha, sir. So Dr. Nakul Sinha, sir, has joined, and I also take a great pleasure to welcome Dr. Sairam, sir. Over to you, sir.
I just saw the chat message of sir. Welcome, sir. I was Dr. Sinha's student. I was trained by him. It's a great pleasure and honor. He joining. I think he wants to just watch this time and then he will come into moderation next time, he said. Respect whatever he says. And then Dr. Sai is also there, but we'll just finish the discussion of this case and then request Sai. Dr. Navjit, you have shown excellent case. In this tough COVID times, also you stood in the lab and continuously did hard work, and then actually opened up these two vessels. But if it was lead 1 AVL, sometimes it is difficult to decide the culprit vessel between RCA and LCX, agreed. But you yourself showed that the patient had lead 1 AVL changes and probably MR assessment. All that was suggesting the LCX involvement. Why did you think of opening a SVG to RCA first rather than LCX?
Because in the serial ECG, I had mentioned when I was presenting the introductory slide that there was 1.5 millimeter ST elevation in the 2-3 AVF. And there was more the ST elevation, even though it was less, but then the magnitude of ST elevation, the coving part, it was more, it seemed, towards the thing in the lead 3. So I thought that somehow RCA graft will be culprit. On the retrospect, when I think because of the COVID, both this graft got occluded at the same time, perhaps because of heightened inflammatory state. It is all a matter of speculation. We don't know. But then the fact that the RCA graft opened so easily is itself a fact that I think the RCA graft was acutely occluded.
Yeah, I missed that 2-3 AVF ST elevation more.
Okay.
I was thinking lead 1. So that's a good point. What sir mentioned, for the sake of everybody, you decide which vessel is involved depending upon analysis of your ECG. That also analysis becomes important. There are some physician colleagues also joined. That's why I'm just mentioning this. I request cardiologists to excuse me. So basically, depending upon the involvement, what territories are involved in the ECG, you decide what is the culprit vessel. Most of the times, if LED, it is easy. Changes will be in the anterior leads. But if it is in the inferior leads and inferior lateral leads, sometimes there could be confusion between RCA and LCX. Some of the pointers, as what sir said, was if the elevation is more in 2-3 AVF, probably you think of right. If it is more towards lead 1 AVL, probably LCX, that could be dominant vessel. But it's very important for us to address the right vessel to open it. And the beauty of angioplasty or giving a lytic drug for that matter is, if the arteries are opened, how much ever inotropes, the critical care people nowadays have the habit, I'm not saying fault with them, it's always they're doing human service in this tough COVID times. Without their help, many of the patients won't improve. But they have this habit of going on pumping high inotropic support in these patients. What I have seen is how much ever dopamines, dobutamines, inotropes you give, unless the artery is open, their pressures won't pick up. Once the artery opens, as shown effectively in the right coronary artery, once you opened up, pressure's picked up immediately. So you have seen this many of the times. That's the beauty of doing a opening of the vessel. Once the open blood flow comes, the vessels get opened, then patients improve dramatically and blood pressures improves. That's what has happened. And the other thing what is shown effectively is that LCX territory, though looks small, it supplies the inferior posterior segment where the mitral regurgitation tends to happen in these patients. That is ischemic mitral regurgitation. And once you open up, MR decreases and patients' pulmonary edema decreases and they improve dramatically. So that is a importance of knowing. Sometimes LCX looks very small, but they tend to improve because of improvement of ischemic MRs also. That is another point which is shown effectively. But because of a very long segment disease, tough COVID times, lot of thrombus burden, sometimes we end up with slow flows. Now, sometimes with chunks of clotting, thrombus seen in left mains, we have used tenecteplase also sometimes in labs to avoid thrombus getting into branches. So here he said he has used streptokinase. That also has established some flow, but probably better lytic agent would have done further better.
Yeah,
but always
actually, sir, tenecteplase is available in the pharmacy.
Yes.
This was at night. It was going on this thing, and at the time patient was unstable. So I told them to give me whatever is fastest, and that was available in the lab only. So we use that.
No, that's
yes,
very good. That's I'm not finding fault with you. That's good because opening is important rather than though we like this molecule and it's not available, not giving anything, then something giving and doing is good for the patient.
Yeah, another point.
And we have data also with urokinase and streptokinase intracoronary. Yes. We have to collect data for tenecteplase by direct intracoronary injection. We don't have too much of data. We're collecting some data where I say tenecteplase is a great rescuer in cath lab. I have collected some data where I've shown where even in cath lab you could take the help of this. Not only pharmacoinvasive strategy, we are going a step ahead where this could be helpful in spite of presence of cath lab. That's what I was telling. I think you have shown these cases effectively.
Another point in line of what Dr. Salil had already told us, in our institute also, 3 cases of mine, we did thrombolysis effectively during the corona time. One was an Afghan lady who had a large DVT along with corona, and she suffered pulmonary embolism, in the massive pulmonary embolism in the hospital. So in the ward only, before shifting to the ICU, we had the echo person saw RARV dilated, and he called us, and we told that give Elexim 60 straight away, and straight away it was given, and we could save the patient. The other patient was a patient having hip surgery, and along with corona, admitted to our hospital. That also we did thrombolysis, but of course we shifted in the ICU, intubated, and all this stuff. The other interesting patient we did thrombolysis here was in a struck valve. Whether this patient was having already some penis or from before, we don't know. But during the corona, he presented with acute breathlessness. The routine test was done, corona was positive. So whether positive or negative, we decided that we have a yellow zone where we keep all the suspects. So we shifted the patient into yellow zone before the report came, and straight away thrombolized with this Elexim. So this resulted in, within 10-15 minutes, his hemodynamic improved. So these 3 cases in last 6 months in the second wave we have experienced. And I think quite as Dr. Sreenivas has also shared, these are our little experiences from my hospital.
Great, sir. You have highlighted other 2 important like unindicated, like off-label indications for using this molecule, but they're great saviors, I would say. Stuck valve, you don't find much time sometimes, then you give it immediately, it works, and patients hemodynamics improve. And as you said, sometimes there could be underlying PANAS which needs to be addressed later, but immediately hemodynamics improve dramatically. And these tough times of COVID, when the patient has arterial and venous thrombosis, it's certain to be COVID. So then again, that sort of conditions also, they would benefit, especially when they go into pulmonary thromboembolism. Then I think there is again more chance of patients benefiting this molecule. And we can discuss what are the indications of giving lysis in that further as we move on. But we need to finish. We have a 3rd case. And we have Dr. Sai, my good friend, joined IMA Hyderabad president. Thank you, Dr. Sai, for this opportunity and making all the local doctors join this webinar. I think I was told that 1,200 plus doctors joined in already. I appreciate all your interest. Any few comments you want to mention, Sai? Any of the doubts or any experiences or anything you want to ask?
Yeah, I was the part of thrombolytic therapy for cancer patients on chemotherapy. I was a principal investigator.
Okay.
So a lot of cancer patients have, thrombosis and thrombolytic problems. And during COVID, we have a lot of these problems. And I was part of this workshop of intravascular brachytherapy. Now, of course, it is not there, but still, we are associated in this way with this thrombolysis and this intravascular treatments. I only request is that we have a lot of interventional radiologists, surgeons, physicians, critical care people joined from my IMA Hyderabad City branch, which has 6,500 members. So I request only to not to use abbreviations because we are not cardiologists, so we'll not be. So as far as possible, try to because we have mixed audience, try to use less abbreviations as possible.
We'll keep that in mind.
Thank
we
you.
can keep that
Thank
in
you.
mind, Sai. And he has also highlighted another important aspects of usage of these molecules. He himself proceeded on to oncology, where the usage of these molecules could help in oncological patients also when they have thrombosis and other things. Thank you. I think we have third case to present and we are nearing time. Over to you, Onkar, to introduce the third speaker.
Yeah, so let's go to the third case, sir. Dr. Preetam Krishnamurthy, sir, would be presenting third case, sir. Over to you, sir.
Thank you, the MQR management and the faculty, learner faculty who have allowed me to present an interesting topic where thrombolysis helps in avoiding an unnecessary PCA. So as pointed out by Dr. Sreenivas sir, that young males are often a subset of population where we can actually avoid stenting. So I will compare two cases where one of them was managed in the pre-COVID era and the other was the post-COVID era during the COVID times, and how the management changed with the pharmacoinvasive approach. So this is the first patient who presented in April 2021, now 37-year-old male, non-diabetic, non-hypertensive, non-smoker, with chest pain for 1 hour, and the ECG showed an anterior MI. He was thrombolyzed with tenecteplase, 30 mg, since there was no specific contraindication for lysis, and he remained pain-free after thrombolysis. Since he remained pain-free, he was evaluated for COVID status, which turned out to be negative. He had a residual LV dysfunction of about 45%. So this was his ECG at the time of presentation. And here we can see after lysis that there's hardly any lesion. There was probably an unstable plaque here, which could have ruptured, could have caused this anterior MI. And after lysis, we can see there's insignificant lesion. And this is a patient where we have avoided doing a PCA. So coming to the next patient, this patient presented a year ago in February 2020, just before the COVID pandemic started. A 35-year-old male, non-diabetic, non-hypertensive, with no dyslipidemia, but a chronic smoker, and presented with the similar duration of chest pain of 1 hour. He was taken up for primary PCA. Our center was one of the most sorted out of primary PCA center in Chennai. He was taken up for primary PCA directly without any thrombolysis. At the time of presentation, he had a moderate LV dysfunction of EF 40% with the LV titration being akinetic and the clip class 2. So ECG was similar to the first patient. And there was some difficulty in taking the radial access, so femoral access was immediately taken. And here you can see there was a significant occlusion of the LAD with the TIMI1 flow of the distal LAD. So we proceeded with the wiring of the lesion with the run-through wire. There was initial difficulty in identifying which could be the LAD, but the wire was parked at the diagonal. Thrombosection was done several times, around 4 to 5 times. So after assessing the thrombus burden, significant thrombus burden, it was decided to crush the thrombus with a stent. So Zain's expedition 3.533 stent was deployed from proximal LAD to mid LAD. But after stenting also, we can realize that there is significant thrombus that is still present, which did not allow the stent to expand properly. So this was post-dilated, despite being an acute coronary setting, because it was placed in the LAD and there was under expansion. We didn't want the patient to end up with the stent thrombosis in the perioperative period. So still we can see the residual thrombus, and the thrombus had migrated to the distal LAD. Many attempts were made to reduce the distal LAD load by ballooning with a small balloon, tirofiban, nicrandyl. And despite multiple drugs, there was the small territory of LAD which still had a cutoff. And since the procedure time was becoming longer and the patient had significant contrast usage, we didn't further do anything to the distal LAD cutoff. Since relatively good result was obtained for the proximal LAD and a significantly large diagram. So what happened to this particular patient? Post PTCA, there was no chest pain. He was further managed with low molecular weight for 4 more days. Initially, his LV function improved to 45%. But this patient was lost to follow-up after 6 months. 1 year later, he became COVID positive. He was non-compliant to his medications, developed chest pain, and this time his ECG showed an interval limit. And now, since he was presenting during the COVID era, there was again a lot of difficulty in shifting him for a primary PCA. So this time he was thrombolized with tenecteplase. Patient was pain-free, discharged after conservative management for COVID. No angiogram was done since he was having active COVID infection, and he was also not having an urgent indication for angiogram, and he again was lost to follow. So here I'm trying to emphasize a point that a pharmacoinvasive approach, we can avoid an unnecessary PCA. This is some of the data from the STREAM trial where it is clearly showed that before PCA, by thrombolysis, a good telemetry flow can be established, which helps in the success rate of a PCA. And also, we can avoid significantly the amount of PCA that is done in a patient with thrombolysis. So in this Indian scenario, it is we have to understand that patients are not able to accept the disease. They contribute to chest pain to various other reasons, resulting in delayed presentation. And there is a low acceptance of primary PCA because of the increased prevalence of COVID, the availability of labs which can do for primary PCA for COVID positive patients, absence of any universal healthcare, limiting our resources, ignorance about procedure. We waste more time to counsel about the primary PCA, which is more expensive compared to a thrombolysis, which is far cheaper, and the revascularization time significantly increases because of that. And the poor compliance to medication, which increases the risk of stent thrombosis. So compared to thrombolysis, thrombolysis helps to establish early revascularization, and when successful, pharmacoinvasive PCA can be planned after proper counseling. So from an intervention point of view, it provides the time to assemble the cath lab tube, reduces the thrombus burden, increasing the success rate of the procedure, reduces the requirement for stenting and hence the risk of stent thrombosis due to non-compliance of medication, and recanalization of the culprit vessel without stenting in patients with significant stenosis helps provide enough time for an appropriate referral for surgery. Thank you.
Thank you, Preetam, for showing excellent cases. I think they fit very well in our theme of what we say, Dr. Onkar and others selected very good cases. Thank you for that. And we see the passion of doctors. That's what I encourage always. We should be willing to do good to the patients, whether it is lysis or whether it is primary PCA, where it is required appropriately. We tend to do the procedures and do good to the patients. And these tough COVID times, you have seen challenging times also that patients do develop repeat MIs and which was being taken. Surprisingly, what is very disturbing is this patients being lost to follow-up. Sometimes, many other times, in spite of lives being saved and all these things happen. And before I further comment, I request Sharma sir to comment any few comments on these two cases, what he showed. Sharma?
Yeah. What Dr. Preetam has shown is a very good presentation of two young patients where we have to do the PCI, where we have not to do the PCI. This drug, in his first case, it is 37 years, interval MI, beautifully thrombolized, and he was get away from the PCI. Without PCI, that patient preserved the LV ejection fraction, I think, within 6 months. But secondly, you see the comparison, that is also 35 years old and having a lot of thrombus. He did a lot of thrombosuction, and in spite of that, he couldn't get the good telemetry flow in distal LAD. So we never know in COVID patient or non-COVID patient what is going to wrong in young patients. In spite of doing the angioplasty, this patient lost the follow-up, and again he had chest pain, interval MI, and see the beauty of this medicine, thrombolized, and there was no chest pain. So I think the pharmacoinvasive therapy in this COVID era is a beautiful combination therapy. We have to accept it. And here in Jaipur, what we are practicing, we are thrombolyzing acute MI setting, and after having the COVID protocol and the result of COVID test, we are taking into the cath lab. We are not doing without COVID test. And I think we can use this electroplates to avoid unnecessary PCI and unnecessarily subjecting our cath lab staff into this COVID era. So I think this is a good approach using the pharmacoimaging. And I must congratulate Dr. Pritam to have this second patient with little bit complication, but he got away. Thank you very much.
Thank you, Sharma sir, for your comments. And other thing, what it is very well shows is in young patients, sometimes many times you avoid using stents altogether with the recanalized vessels. That's what is shown. And we may be identifying some subgroup of patients, very 40 years old, young, with less of risk factors. Probably this could become the treatment of choice where you could avoid doing stenting. But the problem is in occasional patient, it doesn't open, and patient do require PCI further. But at the same time, if patient gets relief of it and probably you check it and the cath lab, it is all arteries are open. That's where I think you feel happy that you are avoiding stents in a young patient because if you are taken for primary PCI, you would end up stenting that vessel. Regarding the recommendations wise, what is recommended to be taken for lysis, and like where there are no facilities of cath lab, there is no issue. In 80% of the population subsets in the country where the lab is not available, the pharmacokinetic strategy is the only way to go. But in centers like Apollo, where the facilities are available also, in the present COVID times, what is recommended is if patient has a small MI, lateral wall MI, hemodynamically stable, doesn't have much of problem, and patient is presenting little late with no pain at all, those are the subsets of patients. I think probably you can follow a conservative strategy. If patient comes within first 6 hours, still you tend to give lysis. And even in that areas, we have identified some specific areas in hospitals to give lysis also for these patients without infecting to others. That sort of each hospital is setting their own things. But as Sharma sir mentioned, we always check for COVID test before we wheel them to cath lab if patient is stable. But if patient is not stable and it's a large patient is unstable with low hemodynamically changes and then probably BP fluctuations, and if your patient is COVID status is not known, that's where I think all the PPE kits, usage of the masks and all this is quite troublesome to do it. But if patient is young and anterior MI where we are forced to do it, we take all the precautions. Level 2 precautions, what is recommended. It's preferable to have a negative suction cath lab, and also mandated to wear N95 mask. We are now following the double mask with a facial shield in front. And sometimes we are not using the PPE kits and covering totally also, but this masking with double mask and facial shield to prevent contamination to eyes also is very important. But in spite of taking all precautions, some of our techs and some doctors got infected. That's why it's always imperative for us to take care of our staff also along with the patients, and to avoid long procedures, especially like what Dr. Navajit sir showed. Then the more longer the exposure with the COVID patient, then the more chances of you becoming positive. That's what another thing we have seen. If you quickly finish the procedure in less than half an hour time and take him out, there's less chance of you becoming positive. And when there is ambiguity, when status is not known, that's where we used to take the help of CT scans before, but we started using it less and less commonly. And then the patient is stable, we would get away by using conservative measures. These are the further things from some changes which we are learning. And when what he has shown, the recanalized, whether we did collect some data about 204 patients with pharmacokinetic strategy. In that, about 58 patients did not require any stent, because when they were shifted to our place and when we took them for angiogram, all the vessels, 58 patients are recanalized vessels out of the 203. We published this data. But only thing is, we need to follow them up with low molecular heparin or heparin. Otherwise, sometimes the reocclusion rates could happen. And that's where we need to identify subsets of patients. In COVID times, they said a lot of thrombus burden, excess burden is also noted. That's where we tend to limit the size of stent if possible to avoid stent thrombosis and things like that. So these are some of the learning points. I think appropriate cases are showed for our thing today, where we can avoid young patients where stenting is totally avoided. That's, I think we should congratulate Preetham for showing excellent case. And then also sometimes when you need to work on the patients, you shouldn't go back, and we should be prepared to do what is good for the patient. In that zoomed picture, what you showed, just for learning, I'm saying, Preetham, if you feel that stent is still underexpanded, somewhere the material has to stay somewhere. So all the time, once you deploy the stent, there is some slight layering, it looks occasionally. But we tend to have a feeling that we want to stretch it further and dilate it. That's where the slow flows also increase. So it's always a thought process whether to dilate it further or stop there. So we tend to decide basing on the patient's pain characteristics. The patient is absolutely pain-free, hemodynamic settled, and the flow is good telemetry flow without much of problem. We tend to leave it also sometimes. But if you stretch it too much, somewhere the material has to go. That's where it migrates distally, and then we do see the distal thrombus migrations after high pressure dilatations. But your point is well taken, because it's proximal LAD. If it is not opposed properly, stents could thrombose. That worry is always there. But I don't think that is the cause for in this patient, because acute MI happened maybe after 6 months. What time you said?
This acute MI was in the pre-COVID time. So this primary PCA was done as in the pre-COVID.
That's what. So that is not the cause. That's what I'm saying is.
No, this is not the cause.
Expansion may not be the cause. This is a new cause which could have happened. And had we had a chance to do angiogram, we would have learned more better things. But it's always patients give a lot of learning opportunities. That is also there. On the other hand, sometimes we get depressed when the patients get lost to follow up. In spite of we telling so many times that we should not stop antiplatelets and start in these tough COVID times, either when you get COVID or when you take vaccination, there are so many times the critical care doctor tells something, or maybe it's not concentrated with patients are kept aloof. Many of the times these drugs get missed also. So that we should avoid. When a patient stops taking antiplatelet, that is actually worst scenario, COVID plus combination of that, then patients tend to get into trouble. I think we are nearing our time. I think I see Mr. Kuldeep sir also joined now. Is there?
Yeah, he's there, sir. He's there.
Okay. And before we close, any of the people who joined has anything to ask or question, we can have some questions taken. I should be extremely thankful to my colleague, Dr. Ramakrishna, who immediately in the last moment also told when there's some Mumbai, there could be some trouble in the presentations at that. He came prepared with a set of cases to show the importance of this. But I think because of paucity of time, I request him to bear with us, and probably you can present in the coming sessions, Ramakrishna. Is that okay? Do you want to say any few words, Ramakrishna?
Oh, it's okay, sir. Next time we'll present.
Yeah, it's a great help to have young dynamic colleagues like Ramakrishna, especially in the primary PCA times. Unless the patient is some VIP or some sort of difficult case, most of the things are taken care by Ramakrishna and Sanjeev Kumar, my other colleague, in the hospitals. That's how they take all the trouble in doing PCA procedures. And this the pharmacokinetic strategy also gives us time for the seniors like Dr. Nakul Sinha sir and me to plan our procedures well, and the patient is stabilized later when he comes. That is another advantage. But one thing I want to mention, though we are very passionate about this molecule, we should never be averse to doing good. Suppose if a patient is not responding, has a pain ongoing, hemodynamic disturbance, we should always be willing to take these patients to lab and do what is good. I think, Sinha sir, they are requesting you to have your few words on the pharmacoinvasive approach, I believe. Is it okay for you to say a few words?
I must congratulate you on the flow of the discussion, because whenever cardiologists are involved, we tend to make things very complicated. So I think keeping it straight, simple, common sense messages, and keeping the patient in the focus is something all of us should aim. And yes, you are right. COVID has made life difficult in many, many ways. And all of us have to cope. We have to make our decisions. And we just hope that what we do for the patients is sort of appreciated by them, because there is a lot of problem also. People start questioning, why did you do this? Why did you not do this? So you need to counsel the patients also these days. But I think it's a good session, whatever part I could attend, and keeping things straight, giving simple messages, and keeping the common sense as the first priority should be good for the patients. Thank you.
Thank you, sir. Thanks for your encouraging words. And our presenters, you want to comment anything on other cases which are presented before we hand over, we close? Dr. Navjit, you want to say anything about cases presented by Preetham and vice versa?
No, both the cases were very nice. I would not have done differently. Perhaps they did an excellent job. The choices of hardware is always a matter of conjuncture. Like all institutes have their own set of rules and own set of availability. All this matters is there, but both the other cases was excellent.
Okay.
I must congratulate my colleagues for that.
Yeah. Sharma sir, any fine words?
Thank you. Nice to join Dr. Sreenivas, and well done all the presenters. And it's my good luck to Dr. Nakul Sinha. And in COVID era, we have the good interaction, and I think we should keep these sessions in future also. Thank you very much.
Thank you. Before I hand over to Acute people, what I would like to just briefly conclude and say about this sessions today is we had introductory comments about this molecule and advantages of this in today's era. In the first case, we've learned how pharmacokinetic strategy helps us to keep the arteries open, though it's not totally plaque-free. Then it helps us to handle the wire easily, and even the diagonal type of bifurcation lesions, you can wire and do a good job to the patients. And it was also effectively showed that patients treated with pharmacokinetic strategy, especially tenecteplase, you had less chance of slow flow happen in the lab, and that's how the patient's result became all right. Second case, which Dr. Navjit showed, is again a high-risk case. Actually, what COVID high-risk features, I think physicians also can learn from that. Patient was hypertensive, post-CABG patient, LV dysfunction, ACS. These are all high-risk subsets for where patients they get into COVID. And once they got COVID, there is some suspicion of having MIs, whether it's from inferior or LCX or RCA. That points we discussed, and he effectively showed how thrombosuction happens and how even the venous graft angioplasty we could see. And that's how when the patients are taken care, once the blood supply becomes normal, blood pressures improve dramatically. That's a message, again, we have to take. Revascularization is, again, very important to make the patients hemodynamically stable. And third case, scenarios which Dr. Preetham showed effectively, that's what I keep telling. It's great help of this tenecteplase in younger patients, where you dissolve the thrombus totally, and then when you take them up to lab, you may not require the stent at all. That's how you could keep patients away from this unnecessary metal. And at the same time, we should counsel them not to lose the follow-up and take these antiplatelet drugs and statins effectively, not to get into trouble in future. I think with this, we had great learning, I feel. And I also thank Ramakrishna, who prepared a set of cases you could present later. And extremely thankful to all our IMM members, Sairam sir, and many of my friends, and the physician group. I think we have to work better to get some of them into our platform also for interaction, Onkar. Next time we'll think like that. Yes. And with this closing things, I hand over to you. And probably whoever wants to say closing comments before we can decide.
So thank you very much, sir. It was indeed a great session today, a first inaugural session of acute myocardial infarction workshop. We had a three interesting cases, and we highly appreciate and very much thankful to your passion about developing this program and putting the things in place so that we have such a magnificent program today evening. And we also appreciate, sir, your passion for pharmacoinvasive therapy, and you want to propagate this therapy for the very useful for the patients, which required to them. So I also thank our thank you very much, sir. I also thank our moderator, Dr. G.L. Sharma, sir. I also specially thank Professor Nakul Sinha, sir, joining this session. I also thank our speaker tonight, who presented very interesting case, Dr. Preetham, sir, Dr. Talukdar, sir, and Dr. Shirodkar, sir. And I also thank the larger audience who are watching across this platform, and IMA members and the IMA office bearer giving us an opportunity to collaborate for this event. Please stay tuned to us. We will be bringing many of these kind of programs and many of interesting cases, which are really useful for our real life scenario to making our decisions easy in real practice. With this note, let's stop here and catch up in another day with the 3 new interesting cases. Thank you very much, and wish you a good time.
Thank you very much. Thank you.
Thank you.
Thank you. Bye-bye.
Yeah, thank you, everyone.
Bye.
Thank you.